My name is Lindsay Miller. I am a 10-year papillary thyroid cancer survivor, 11 years, I guess, and I have hypoparathyroidism, so I'm very excited for this session. I'm pleased to introduce Dr. Albuja-Cruz, is an endocrine surgeon at the University of Colorado School of Medicine in Aurora, Colorado. Board certified in surgery, she is an assistant professor of surgery in the Division of GI, Tumor, and Endocrine Surgery. Among her repertoire of specialty procedures, Dr. Albuja-Cruz is well-versed in minimally invasive parathyroidectomy using intraoperative parathyroid hormone monitoring, total thyroidectomy with central and modified radical neck dissection, and laparoscopic adrenalectomy. So thank you.
Thank you, everybody that's here, and thank you, everybody who's listening on this Zoom. Today, I'm going to be talking about how to manage post-thyroidectomy hypocalcemia. And I already know that you had it. Is anybody else here that has hypopara? Yeah. Is anybody here that has not had surgery yet? So probably a lot of what I'm talking about, you guys already know. But why we're talking about hypoparathyroidism in this conference, and it's because it's the most common complication for thyroidectomy, and is actually the most common reason why an adult would have hypothyroidism, because there are other etiologies for hypoparathyroidism, but in the adult population, post-neck, anterior neck surgery is the most common cause. For every 17 patients that undergo a thyroidectomy, unfortunately, one of those are going to have issues with severe hypocalcemia. So truly is a big problem. So why hypoparathyroidism occurs after thyroidectomy? Or what I meant to say was the definition of hypoparathyroidism. So that's a low calcium level associated with a low parathyroid hormone level. So the parathyroids are little cells that are just behind the thyroid. And what those cells do is they have some receptors that will sense your calcium level in your bloodstream. So when your calcium level is low, those parathyroid cell receptors will sense that and secrete more parathyroid hormone. And what that hormone will do is activate cells in your bones to take calcium from the bone and put it in the bloodstream. It will activate your kidneys to absorb more calcium, and it will also help you digest and absorb more calcium. However, when we don't have that hormone, all those things will not happen. So patients will have issues absorbing the calcium from their diet. They will not concentrate calcium in your urine despite the calcium is pretty low. And also your bones are going to retain more of that calcium, and that's why they become hypertense. After an operation, you can have temporary hypocalcemia or hypoparathyroidism or permanent hypoparathyroidism. And the definition is primarily time. So if you are taking calcium or vitamin D 6 months after surgery, likely that's permanent hypoparathyroidism. And how that's going to affect quality of life depends a lot into the severity of it. It's not the same to take a few calcium pills as to have to inject recombinant parathyroid hormone. The association of this significant complication goes down if this operation is done by an experienced neck surgeon. So why does this happen after surgery? So one is because these little parathyroids can be injured during the operation. They can be devascularized. They can be removed accidentally with a thyroidectomy. One of the ectopic locations of these parathyroids can be inside the thyroid. So even a very great surgeon that knows how to preserve them, those parathyroids can come out because they're inside the thyroid, and that's not very hard to see. But fortunately, that is not a common problem. And only is going to be one or two of the parathyroids inside the thyroid, just how they descend when you're a baby. So at least two of the other parathyroids may be able to be preserved. And sometimes just the pure manipulation of the glands causes this temporary stunning, as we call it, and that recovers with time. So here you see the anatomy of the parathyroid. So this is the thyroid gland. This is
medialized, and you can see the parathyroids are these yellow structures over here. And you can see they share a common vasculature. This is the inferior thyroid artery, and this is the little vascular pedicle. So in order to preserve the glands, one has to stay very close to the capsule of the thyroid and not do a ligation of this inferior thyroid artery. Once you ligate that artery, there is not perfusion to the gland, and the gland is not likely to work. So what are the symptoms of hypoparathyroidism? You can have loss of strength. There's numbness and tingling in your fingertips and around your mouth. That's what we call paresthesias. Tetany means contractions of the muscles. It can be more severe, like laryngospasm or bronchospasm, that can cause somebody to have respiratory issues in cardiorespiratory compromise. There can be changes in your heart. They can be palpitations. They can cause edema, cardiomyopathy. Some people have difficulty concentrating. It's what's called the brain fog. There can be changes in your mood and ideation. People can have chronic headaches, trouble sleeping, fatigues. Patients can develop seizures and something called papilledema, which is swelling of the optic nerve, and that can cause like issues with your vision, including losing your vision. So severe consequences. So what can one do to reduce the risk of hypoparathyroidism after surgery? And again, the most important part of it is to have the operation done by a high volume surgeon, because they will know how to perform a capsular dissection and how to preserve the perfusion of the parathyroids. There's also the need to identify patients that have a high risk of having these complications from surgery. Also, there is consideration about the evaluation and treatment of low vitamin D before surgery. And there's some talk about using new technology like infrared fluorescence imaging to try to identify the parathyroids during surgery. So what is the impact of high volume neck surgery and the outcomes of thyroidectomy? So this is a recent systemic review of trying to answer this question. So a systemic review is basically they evaluate all the papers or articles that are talking about this high volume surgeon, and basically they give a summary of what they found. And once again, a high volume surgeon is a significant predictors on the outcomes. One, the higher the volume the surgeon does, the less of the complications they will have, but also very important in regards to the oncological outcomes of the operation. So if the surgeon does a lot of thyroid cancer surgery, there is less likely that there is going to be recurrence of the disease, and that you have the most complete operation the first time, which also decreases the risk of having a second operation, which increases the risk of having complications. But this article also talks about the importance of a hospital volume. And I think that's important because of the rescue, especially immediately after surgery, the ability for patients to being recognized that they are having issues with calcium, high calcium or low calcium after the treatment of it. And also it says that whenever these thyroidectomies are done in high volume centers, there is decreased mortality, the decrease of the length of hospital stays. It tends to be cheaper. There is a strong recommendations on all the guidelines about the high volume surgery, how about doing the thyroidectomy, but then there is discrepancy of what is the definition of high volume surgeon. So some article says more than 25, more than 40, more than 50, more than 100. So it's very hard to define as a patient what is a high volume surgeon, but they said it's relative also to the density of their population. So you live in a place like Denver that is very populated, probably you want to look into somebody that does more than 100. So I understand it's everybody and all, we all say high volume surgeon, but it's very hard to define what that is. So one of the patient population that has the highest risk of having refractory hypocalcemia is patients that had gastric bypass surgery. or any other disorder that will affect the absorption of calcium and vitamin D, such as example, celiac disease. And why is the gastric bypass such an issue? Is because part of the operation is to bypass the small bowel, the first part of the stomach and the jejunum, which is where primarily your calcium and your vitamin D is going to be absorbed. And also because they remove part of your stomach, that decreases the acid in the stomach. And in order to absorb the calcium, you have to have acid. So that's why it's important also the form of calcium that one takes. So if you are somebody that takes antiacid medication, just taking calcium carbonate, which is the TUMS, is not as effective as to take calcium citrate that comes in with the acidity that needs to be absorbed. So what are the recommendations that some experts have when you are doing an operation for people with gastric bypass surgery? Is one, the preoperative evaluation for vitamin D deficiency and to treat it. Two, they recommend that the patients are start right away after surgery on IV calcium. As we talked before, they will prefer oral calcium citrate and calcitriol immediately after surgery. They recommend to do a stage surgery. And what that means is instead of going ahead and doing a total thyroidectomy, first doing a lobectomy. And I think if there is all the strategies and the patient has significant hypocalcemia that cannot be managed, some patients need reversal of that gastric bypass surgery. So a big deal. So what is the evidence about vitamin D deficiency and its increase in the risk of hypocalcemia after surgery? So we did a study and we found that vitamin D deficiency is very common. About 40% of patients have vitamin D deficiency, but we did not found any difference on biochemical or symptomatic hypocalcemia in patients that have vitamin insufficiency or deficiency. Our results have also been shared, been fine, but this review is another systematic review of the literature. And they didn't found that, again, having vitamin D before surgery, vitamin D deficiency before surgery cause issues with hypocalcemia. However, it's not something very hard to evaluate. And I don't think it hurts anybody to have vitamin D replacement prior to surgery. This study also talks about the administration of calcium and calcitriol 1 to 3 days before surgery. And they have done 9 trials to try to identify if this will help reducing the risk of hypocalcemia after surgery. And they found in 7 of the 9 trials that they actually cause a reduction on the lab work showing low calcium and also the patients being symptomatically hypocalcemic. So in regards of things that surgeon can use to try to decrease this rate during the operation, there is now, we have the ability to use this infrared fluorescence imaging during surgery. So we inject a dye into the patient's veins, and then with the use of some special lining, it helps to identify the parathyroids. So what the study shows is, yeah, it decreases the risk of parathyroids that are removed accidentally, but truly does not change the rates of hypocalcemia. And I think that's, again, goes to the fact that it's very important not only to preserve the organ, but also its vasculature, because it can stay there, but if it doesn't have vasculature, it will not work. So now how to manage after surgery hypocalcemia. So I think one of the most important things is education of the patient. And the reason for it is educating about how to treat it and also how to recognize the symptoms of hypocalcemia. Then it's very important to assess what is the risk of the patients to have hypocalcemia after surgery. I think it's also important that wherever place the surgery is done, they have a standardized protocol to manage the hypocalcemia, and that the patient have a monitoring of the calcium levels. And also, again, into the education, also the importance of taking that calcium and vitamin D supplementation after surgery. Because I think if you have not had the problem of low calcium levels before, I think that the importance of it is minimized because it's just calcium. It just sounds like a replacement, a supplement. And patients say, well, it seems like it's just a few pills of calcium. They don't take it, and then they will experience the symptoms of hypocalcemia. So this is is this a meta-analysis about what to do, what's the best way to prevent hypocalcemia after surgery. And the most important way to do it is just in this paper to just start calcium in everybody. And then determining what is the risk of that patient of having hypocalcemia and add the calcitriol. So basically that's kind of the best treatment that there is to avoid hypocalcemia. We use a protocol in our institution that we developed since 2015. And we basically stratify patients in 3 different risk categories. What is important to understand is as a risk of having hypocalcemia. It's not necessarily that that's going to predict that you're going to have low calcium levels for the rest of your life, but it stratify you on the risk of developing hypocalcemia. And based on that, we determine if you need calcium and calcitriol, just calcium or nothing. And how we base this stratification is on the PTH levels and calcium levels right after surgery. If you look up in the literature, there's a lot of protocols, and all of them use different numbers and different supplementations. And I think that is not as important as to follow the same thing all the time. And because that creates an idea of how safe is the patient to go home, as an example. And we find out by starting immediately, as other papers have shown, the calcium and the calcitriol, you decrease the amount of time the patients are in the hospital and also of them having symptoms of hypocalcemia. So that explains a little bit more of our protocol. In the high risk category is we consider PTH level less than 10, but you can see that we stratify that in 2, PTH level less than 1 and PTH level between 2 and 10. And the reason for this sub-stratification is that, surprisingly enough, we have sent patients with a PTH level between 2 and 10 with a little bit higher dose of calcitriol, and they develop hypercalcemia a week or 2 after surgery. So that's the reason why we sub-stratify to try to minimize that risk. And then the moderate risk, we just give them calcium. On the low risk, no supplementation. Because even though calcium is not cause significant adverse effect, I think some people it could cause constipation. Some people have bloating, abdominal pain. So if we don't need to add more stressors in the patient's life, I think it's better. So I think that patient education, I think, is extremely important. And the reason for that is 40% of patients are going to be experiencing the symptoms of severe hypocalcemia when they are discharged from the hospital, despite they were given calcium and calcitriol. And I think part of it is some of them, they're discharged on the medication, but they don't take it because they don't understand the importance of it, or truly how long it takes for the calcium to drop to its lowest is about 3 days. So we usually send patients home after first night from surgery because they're doing pretty good, but we will not see that nadir or the lowest the calcium is going to be until about 72 hours. So it's important for them to know how to take the medication and also to know how to get help about it and what to do right away. And that's why I call failure to rescue. And that means that about 75% of patients that experience these symptoms after discharge, they always have symptoms that are milder before. But if the patient doesn't know that those symptoms represent low calcium, it's very hard for them to ask for help or to remember about taking the calcium. Because I think that when we see the patients to recommend surgery, is usually a first visit. And during that first visit, it's hard to know how much a patient gathered because it's a lot of shock news. 1, you have cancer. 2, I need surgery. And I think probably there's just a few things that they are missing. And we try to assess the understanding of that by testing patients during the consultation. But that's also not fair to do in that visit, because again, there is a lot of emotions that are going through that. So because of we recognizing the importance of this education, we do more education before the patient go home. And nowadays, also we're calling patients 2 days after surgery because we know the level, the calcium is going to drop the lowest at day number 3. So having a call the second day with a nurse to make sure that you're taking the medication you're supposed to take, because sometimes we fail to communicate that calcium and calcitriol, they sound very similar, are 2 different things. And the calcitriol, the hospital will give to you the prescription in combination with the other medications. So I wouldn't think that, well, that's all I need to take. But the calcium supplementation is something that you get over the counter. So sometimes patients don't realize that and they're just taking the calcitriol. So I think we're trying to fail to rescue by having another contact with the patients 2 days after surgery. So this question is, how will know if I have permanent hypoparathyroidism and how will this affect my quality of life? So the definition of chronic hypoparathyroidism is established only 6 months after surgery. And that's basically to have a low calcium and low PTH without the supplementation, or if you continue taking the supplementation and you cannot be wean off of it. Unfortunately, it is shown that patients that have permanent hypoparathyroidism has a significant diminished quality of life. What they call people is like that brain fog, and is a very one of the most common complaints of patients. And unfortunately, this complaint happens even if the calcium levels with a conventional therapy has normalized your PTH and calcium levels. And unfortunately, that therapy does not improve the well-being. So other symptoms of patients with chronic hypoparathyroidism experience fatigue, muscle cramps, the numbness and the tingling. They can also have the tetany and joint and bone pains. And also there is a high rate of complications from the treatment of the hypoparathyroidism, like hypocalciuria, that means peeing a lot of calcium, and that increase your risks of calcification and kidney stones. So it's now like a play of balancing, not too low, not too high. Also, your kidneys can get affected, and there can be calcifications in your brain. So this is a systematic review about the quality of life in patients with hypoparathyroidism after the treatment of thyroid cancer. And once again, it's just demonstrating the impairments in the quality of life on patients that had the hypoparathyroidism compared to patients that did not. So significant lower overall health, physical functioning, emotional functioning, social functioning, and also they have higher scores in fatigue, pain, dyspnea, and trouble sleeping. So these are the guidelines on how to manage chronic hypoparathyroidism. So the conventional treatment for it is the calcium supplementations. If that's not enough, you can add on vitamin D, like the calcitriol. Very important magnesium supplementation, because magnesium helps with the absorption of calcium. Another medication that can be given in those patients that those 3 first ones do not work is thiazides. That's a diuretic that helps you absorb more calcium. And also very important to focus on the phosphate, because when you have hypoparathyroidism, your phosphate levels can go up. So we have to find a balance. So those are the goals of the treatment. And one of them is to prevent the symptoms of hypocalcemia. But I think it's very important, as the second one is to maintain the calcium level slightly below the normal low. So it's between 8 to 8.5. So you don't want to go above that because that is when you start having risk of having issues of kidney stones and calcifications. And that goes along to the third one. And so you want to have that calcium phosphate product below 55, because that's what increases your risks of causing these calcifications. We don't want to see hypercalciuria. So if you have chronic hypoparathyroidism, it's very important that your doctor is looking into your calcium level in your urine. So you got to collect that for 24 hours and then look into the calcium level there. And also not to have hypercalcemia. And it's very hard to determine who is going to develop that. But that should be one of the goals of the operation. And again, all of this therapy will prevent to have any calcifications in your kidneys and anywhere else in your body. There's also here more of the guidelines and what to monitor. And we talk about the phosphate levels, the 24-hour urine, and also asking questions or doing tests to determine if there's kidney stones, like with renal imaging. Patients need to be evaluated for cataracts because hypoparathyroidism can predispose people to have cataracts. Also, we talk about calcification in the basal ganglia, so that will need to be also evaluated. And your DEXA scan, so your bone mass, because patients tend to be hyperdense, and that also could potentially increase the risk of fractures. There's a different, your bone remodeling is affected by the hypoparathyroidism. So this is in relationship to the recombinant parathyroid hormone. This was FDA approved in 2015 for the treatment of hypoparathyroidism for those patients that cannot be well controlled with calcium and calcitriol. So there was a multinational randomized double-blind placebo control trial. So this is of all the studies that one can do, this is the best type of study when they do a double-blind randomized. So that basically means that the patient didn't know if they were taking the calcitriol or the placebo, and the physician that was given to them, they don't know if they were giving placebo or the medication. So then you avoid biases. So in this study, what they found is that the patients that were taking this hormone, they have 50% reduction of the amount of calcium that they needed to take, the amount of calcitriol that needed to take. And that the calcium levels with the therapy remained normal. And they didn't saw any of that on the patients that were taking placebo. So that's the difference of 53% versus 2%. So what are the indications for your physician to consider the use of this recombinant PTH? One, as we discussed, if you cannot control your levels just with the medication. Two, if that you are in the max amount of the calcium and calcitriol that can be taken. Three, if you start experiencing complications of hypercalcemia, kidney stones, renal failure, if your phosphorus and calcium products are now exceeding 55, because again, that's predisposed to have calcification. If you have issues with malabsorption. So for example, we just talked about gastric bypass, celiac disease. Those patients are going to be giving extraordinary amount of calcium and calcitriol. They don't absorb it. It will not work for them. And I think another important one is if the patient experience reduced quality of life. It's important to know that they have this black box warning about the use of this medication, and is the risk of osteosarcoma. So what are the effects of this recombinant PTH in quality of life and muscle function? This is a randomized control trial, and when they were assessing patients with hypoparathyroidism and giving them the recombinant parathyroid hormone compared to placebo. And they find out that unfortunately, the hormone did not improve, taking the hormone did not improve quality of life or muscle function. This one is part of the multinational randomized control trial where they get to identify how good this recombinant is. But they didn't find any improvement in quality of life when they look at overall. But they found out that in some people, there is some improvement on the physical component of the score and the body pain, general health, and vitality. But what is important about this study is that they noticed that the patients that have the lowest quality of life scores are the ones that are going to have the highest benefit for that parathyroid hormone recombinant therapy. So, and that's why a low quality of life is part of the indications for this medication. And this is another study in which they kind of agree on the findings of the prior one, but it's 8 years throughout this therapy. And they found out that the patients have higher quality of life that are not expected, that they have not seen on patients not taking the medication. But they found the same thing. When your quality of life scores are very low at baseline and they are shorter, so they didn't let you do chronic hypoparathyroidism for too long, your improvements are significantly higher. So, and also part of the study have shown that they will definitely reduce the amount of calcium and calcitriol supplementation, and that per se is another predictor of improvement of your quality of life. And that's all I have for you today. And if you guys have any questions, please feel free to ask me. Thanks. Oh, sorry.
The Zoom people.
Hi, thank you for that. I have not heard some of this information, so it explains a lot of the stuff that what I've been experiencing. My question is around, you talked about denseness in bones. Have you or any of the studies seen denseness coming like in the jaws or the mouth area? Because I was just recently diagnosed with like basically a dense jaw, and my teeth. I've had medical teeth issues since my thyroidectomy, and I do take calcium and calcitriol, and I've had to retake guess what is the word, change my calcium because my body has stopped absorbing different ones. So I guess my question is, have you seen the denseness happen in people like in their jaws, or is it just other places in the body?
But the bone density scans basically I'll focus on bones like large bones like your hips, your spine. If you order specifically when we are doing the opposite, but for hyperparathyroidism, they will include your left forearm, but it just give you an analysis of the density of your bone overall. But I'm not sure if your jaw issue is related or not with that amount of calcium you take. Yeah, but definitely, I think it will be important for your physician to monitor your calcium to phosphate ratio, and also 24-hour urine collection. Make sure you're not overdoing it.
I'm sorry. I was just wondering how often a 24-hour urine should be obtained from a patient that is known for having all these issues.
I think they recommended it once a year. So if once you are in a steady rate, it's 1 a year of checking all this lab work. If you're into trying to get into a steady rate, then the check of the lab work should be more frequent.
We have some questions on the Zoom. So one question, and I think you might have answered this, but what would be your standard of a high volume surgeon? Would it be more than 1,000 surgeries?
So I work in a high volume center and I work with high volume surgeons, and I will say that my partners and I probably do over 250 cases per year. So I think that's an adequate volume. I think the difficulty is when patients don't have access to that. And I think that becomes a problem because we would love everybody to go and see a high volume surgeon, but that patient may not have access to it. So that's why the number changes to the density of the population and the access, because they may have a very great general surgeon that does a lot of thyroid operations, and he may be very good, but then one will also hope that that surgeon knows where the limitations and which patients to send out. But sometimes that doesn't happen, unfortunately.
We have another question here. Someone indicates that they are 24 days post total thyroidectomy, and their surgeon suggested they start weaning off their calcium this past week, but they're also on calcitrol. So should they come off the calcitrol at the same time?
So what I recommend for my patients, I will assume that that person have a PTA and calcium level checked. So I would recommend to stop the calcitriol first, and then to continue the calcium at the rate they order it for a couple days. If no return of any of the symptoms, then go to twice a day the calcium, and then once a day. And waits in between changes a couple days. And if they experience symptoms, to go back to the prior dose they were taking, and then contact the surgeon's office to be monitored again.
Any other questions in the room? Okay, go back and forth here.
Hi, I'm just wondering, are there any research or clinical trials going on that address possible replacement of parathyroid tissue, the glandular tissue?
That's a great question. I think they're trying to generate organoids, but I think it's not in use yet. There has been some discussion about transplantation, not like auto transplantation, but finding relatives. But it's not something that is covered by insurance. One of my partners was going to do his first transplantation of parathyroid of a relative. So they found that the sister and her were matched, but unfortunately insurance didn't cover it, so he couldn't do it. Because the procedure, it will not be technically difficult to do. We have 4 parathyroids, we need 1. So if you have a relative, a member of your family that's willing to donate 1, I think that will be ideal. We don't know yet what will be the regimen of immunosuppressive medication that we will take. So we don't have knowledge about those aspects. But I think it is common enough, but fortunately, most people are just temporary. Not many people for the rest of their life. And for those, most people are okay just with calcium and calcitriol. I think it's just a very small subset of patients that have very, very severe hypocalcemia. Thanks.
Nella's asking, at what point do urinate studies need to be done? At 9 months post-op, path was 12. Symptoms are minimal on calcium and calcitriol. Now I'm a year out and wondering.
Probably yearly, and now you should do a calcium check. Your doctor will also look into what is your calcium levels, your PTH levels, your phosphate rate levels, your calcium to phosphate ratio. But definitely one urinalysis should be done in a year.
Hello, I've been using it for 30 months. My quality of life improved greatly. I think it might be in reference. I'm not sure what it's in reference to. My fear are the long-term risk. However, I read about people using it for 12 years and ongoing with no significant risk present. The risk of ascarma that was in rats and super bigger doses, are they real in humans?
She's correct. The black box warning is because they found it in rats, but I don't think it's something that is common in humans. And it seems to be a good therapy for people that's working for them. And as I show the 8-year study, like if your quality of life improved, it seems that those improvements are consistent throughout the usage of the therapy.
The next question is, how does menopause impact calcium levels and symptoms of hypocalcemia?
That's a great question. I have no answer to it. I know menopause is a very difficult thing for women. I don't know how the changes in estrogen will affect. What it could affect is the risk of osteoporosis that a woman that's menopausal has, but not necessarily on the symptoms.
Do you have insight on presentation to FDA by Ascendis Manufacturing controls on TransCon PTH and likelihood of FDA approval?
No, I don't know anything about it. Thanks.
Someone is, I had a total thyroidectomy. Can I develop hypocalcemia a long time after the operation, like a year after?
That's a great question, but no. If you didn't have it, you would not develop.
Let's see. What is something we should know that we might not have asked about that is commonly asked? Just to reconfirm, once a patient is hypocalcemic, is there no way they can reach WNL via dietary means, strictly supplementation, correct? So can they just adjust with diet?
They could adjust with diet, and that will be determined by the lab work. If they are not taking any calcium supplementation and vitamin D supplementation and no symptoms, they don't have to take it. But if their calcium is pretty low and the PTH is low and the dietary does not keeping the levels to a normal range, then they need supplementation. Probably, I think that something that's very confusing in the literature is about parathyroid autotransplantation and how that affects the risk of having hypocalcemia or not. Because I have patients that come, they're very upset because the prior surgeon took out the parathyroids and minced it up and put it on the neck. And actually, I think it's a good thing in a way, because if the surgeon recognized those parathyroids on the central neck that was coming out, or in the thyroid capsule, or noticed that it was devascularized, putting it back on the muscle of the neck is actually a good thing. However, when you read it about it, doing that predicts that you're going to have hypocalcemia. And it makes sense because it takes time for that tissue to revascularize and work. So sometimes patients are upset about it when it's a good thing. And probably that's one question that I forgot to put in here, is that how that improves hypocalcemia rates as a chronic hypocalcemia. But temporary, it increases it.
Someone is asking, when does one need to do a brain scan to see if hypocalcemia is impacting their brain?
I'm not sure about the guidance of that. Fortunately, I don't manage that. Chronic hypocalcemia, hypoparathyroidism. I will imagine if it's somebody's having evidence of calcification somewhere else in the body and have symptoms of new seizures, probably they will want to get a scan.
Thank you. My question is, so, and this is, I hope this doesn't sound morbid, but how long can you live taking the amount of calcium and calcitriol? Are there studies that show the lifespan for someone who has to take this daily? So I've been taking it now for 8 years constantly, like really high doses, because my body does not absorb. So my question is, how long can I live like this? Or are there studies that show that? That's why I said I hope it doesn't sound morbid, but what are the studies showing?
I don't know if there's any study have looked into how long you can live taking out that amount of calcium. But what the studies have shown probably is what is the risk of potentially developing complications from it on the dosing, and how to prevent that. It's just with the monitoring and adjusting.
I'll go morbid, Lindsay, if you don't want to. So I was only told maybe 4 or 5 years after total thyroidectomy, radioactive iodine, hypocalcemia, never going away, hypoparathyroidism. It wasn't until I was with my endo that she told me that it could potentially be fatal. No one had ever really communicated to me that this is bad and it's painful and it gets worse as it goes on, but you leave it long enough, i.e. 3 days, and it can be fatal. Like, I would just guess, anecdotally, is that something that, obviously, there's a right time to tell people that, not immediately after, you have cancer, by the way, this could also kill you, but just that sense of how do you communicate to people that it can be fatal if you just leave it?
I think it will be extremely rare, extremely rare for somebody to die of hypocalcemia. So if you're being treated for it, it's not fatal. It's not that, oh, I'm doing the right things and I'm just gonna die. It's just, if you stop the treatment and you have severe hypocalcemia and basically ignore all the symptoms of my hypocalcemia, because you die with hypocalcemia if you get laryngospasm. So basically your vocal cords close and you cannot breathe. So you got cardiorespiratory arrest. You can die if you don't take the calcium and you're hypocalcemic severely enough that you have changes in your heart rhythm. And those changes go into something called torsar de points. And that's gonna degenerate in all these technical names, in ventricular arrhythmia, which is gonna end in cardiovascular arrest. So it is a kind of starts with palpitations, so it changes arrhythmia. You can die from it if, again, if you have a very severe seizure and you cannot breathe and you have respiratory arrest. But I have not ever seen nobody dying of hypocalcemia. I would say if somebody cannot take the medications from other reason for many days, but I think that's extremely rare.
I just want to make a point of saying that I think education, which was on your slides many times today, is a big factor. And so you might not want to do it immediately post-operatively, but however, there has to be some education, maybe on a post-op visit, on how to check to see if your calcium is low. People might not know about the tingling and, the tapping on the cheek and having those signs, or putting a blood pressure cuff on and having your arm jerk up. Those are things you can do at home, really, if you have a blood pressure machine, or just tap your cheek. So education really is key to let you know that your calcium is falling.
I guess that I'm curious to know, you guys as patients, how we can do this better, how we can do the education better. Because I think that doing it in the same pre-op period, maybe not the best, but you as patients, what do you think, how it should be done best?
The other thing I just want to say is I think it's so rare that I feel like other than my endocrine doctor, which I feel like I got the one in my practice that understands hypoparathyroidism, I go to other doctor appointments and I feel like they don't understand what I'm talking about. You list through kind of what medications you're on and what other, and I don't even think other office staff particularly, maybe the doctors at least kind of know what I mean, but I don't always feel like I'm usually the expert in the room on it. There is another question in the chat. Should renal ultrasound be part of surveillance or renal calcification?
Oh, for renal.
Yeah, that's the recommendation. So you guys are gonna give me an idea. I need ideas to make it better.
I got a little emotional back there. So I actually stayed in the hospital 7 days because I stayed for 7 days, and I think my doctor made the right call, because they said if you leave and you could have a calcium coma. So I think doctors need to be direct with patients, especially if you are potentially if they know you're going to be hypocalcemic or have hypoparathyroidism, and my doctor knew immediately, to take that extra step to have the care. And I know now that the protocol is like 2-3 days max, send them home. But if you know that a patient's going to have that, to kind of push the insurance company or the staff to say, we need to monitor this patient a little bit longer. And so he kept me there for 7 days because of that. And so that would be my recommendation, because I know I've experienced, and talking to these two ladies last night, we experienced very similar things that some folks just don't understand. The other thing I would say, you just give a what could kill you, right? And that's where I got teared up, because I experienced that, where my vocal cords stuck together and they kept sticking together and I couldn't breathe. And it happened many, many times. And my doctor never told me that it was because I was hypocalcemic. He just sent me to a vocal specialist. So I think transparency and telling patients this is happening because of X, Y, and Z. That would be my recommendation.
So how should I tell you about those risks? Before surgery, only if you have the risk of that happening, on a paper, on a video? Because I think different patients are different learners. But what will be for you guys easier to access to? Like a document? Because we send all this information in the discharge paperwork. But then I say, okay, print out the discharge paperwork. And I look at it, I'm like, oh my God, I will not read 10 pages. And then how you make it so it's easy to find exactly what you want to know. And I think that sometimes now with the messaging, the patients have ability to do. There's so many of those messages that nurses and physicians get, that the important ones are not taking with, I would say, the immediacy or urgency that is needed. And sometimes the patients doesn't know, as you guys know, like, this is important, this is like, I'm telling you, I'm feeling this. I don't want to end up in the ED. And that's what I mean, a failure to rescue. So if patient is telling us something and we do not didn't get the message, or I don't know. So I'm just trying to figure out, or I have patients that take like way more calcium than I prescribed, and they come with the opposite problem. To the opposite problem, like, oh my God, how this is possible. So there's definitely, I'm picking your brains and ways on how we can make this better.
I think they were just answering your question. So Nell said the best time would be the post-op visit. Printouts don't go that far. Someone else, Julia, said visual patient education reminders and the proper channels on what to do with potential scenarios that are picture focused. And then someone said some people have poor eyesight or speak a different language, so pictures are always the best versus writing.
And pictures, like a little book of pictures, or
What's like that? So a picture of so something like
I have a question for you, kind of from my own personal experience, just to see if you've heard of this. But so I was hypoparathyroidism for 7 years, and then I got pregnant and had a son. And after I gave birth, my calcium leveled out, and I didn't need to take calcium supplements anymore. So I was like, oh my God, pregnancy cured me. And then it turned out that I stopped breastfeeding and my calcium plummeted. So it somehow was correlated to the fact that I was breastfeeding. When I was breastfeeding, I didn't need to take any calcium. My calcium was normal. And then as soon as I stopped breastfeeding, my calcium plummeted. I asked the question last year via virtual session. I don't remember who the presenter was, and he did seem to have some explanation for it, but it was a little bit over my head, and I don't remember exactly what. But I think it had to do with the hormones, or yeah. Any final questions? Well, this has been great. Thank you very much.